That's right.
Because then I put it on my YouTube channel. Anyway, so for salivary this year, we're doing something a little bit different. As you all know, we've done our fun Jeopardy game. My prior salivary lecture is already recorded on YouTube, so I didn't feel like it was necessary to give that one again. So today we're going to focus on specifically immunohistochemistry in salivary gland tumors. And next week we're going to do core biopsies, which is organized by myself and Katie, because differential diagnosis on core biopsy can be challenging, and hopefully you can use some of these immunohistochemical techniques to kind of inform your differential diagnoses. Yeah, so let's begin. If you guys have questions, please put them in the chat or just unmute yourself and ask. I'm happy to stop at any time if you guys have stuff you want to talk about. So we'll discuss the differential diagnosis of salivary tumors based on morphologic patterns. We'll evaluate how immunohistochemistry and, importantly, genetics may be useful to differentiate tumors with similar morphology. And we'll talk about why these behavioral differences are important. So salivary tumors are rare, as you know, and most are benign. The most common adenoma is pleomorphic adenoma, followed by Warthin, and the most common carcinomas are mucoep, acinic, and adenoid cystic. What's most important on biopsy versus resection are follows. So biopsy is often FNA, but not infrequently could also be a core. What's important is to determine, is this a primary salivary type of tumor or a metastasis? Because as we know, some of your major salivary glands can have lymph nodes in and around them, to which other tumors can metastasize. We want to determine the histologic grade, low versus high. And by low, I mean both benign or low grade malignant. On biopsy, this is kind of nice for us because if it's either benign or low grade malignant, usually these will be resected with an attempt for negative margins, rather than something that's overtly high grade, which they may opt to do a neck dissection. So I don't always, definitively make a diagnosis of a benign versus a low-grade malignant. You can say low-grade salivary gland neoplasm or high-grade carcinoma, because as you'll see, histologic features can be very overlapping. On resection, of course, we want to, again, confirm that it's a primary versus a met, confirm the grade, discuss the margins, and of course, stage the patient. Just as a reminder, our salivary, grossing procedures are all here, including some different techniques you might want to take intraoperatively if these ever do come for frozen. So we'll talk a little bit about sort of, again, benign versus malignant, low versus high grade. We'll talk about how to distinguish tumors based on the number of cell types, the immunostains, and the genetics. If you look at, PubMed, salivary immunohistochemistry and salivary genetics are, swarming with articles, over 10,000 plus 6,000. So how do we put this information together? Because some of it's good and some of it's bad. And so that's what I'm going to try to do today. This is a chart of all salivary gland neoplasms that kind of highlights my concept, my just global concepts about them. How many are composed of one cell type, two cell types, and three cell types? What are their genetics? Do the benign tumors have a malignant counterpart? And what is the usual grade of that malignant counterpart? Because not all have a benign counterpart, as you can see, and not all benign have a malignant counterpart. So when we talk about the microanatomy of the salivary gland, this will help our immunohistochemical profile. So the normal ducts, as well as the acini, have inner luminal epithelial cells, as well as outer abluminal, either contractile myoepithelial cells or just basal cells, which are non-contractile. The acinus is composed of either serous or mucinous cells plus an outer myoepithelial cell layer. The intercalated duct, which are these small ducts between acini, are simple cuboidal epithelium plus myoepithelial cells. And the larger striated ducts are these cuboidal to simple columnar cells, kind of oncocytoid almost, with generally more basal cells as opposed to contractile myoepithelial cells. So you can see there's a shift in that outer layer as we march up the duct. The large excretory ducts are these almost pseudostratified columnar cells that have basal cells only rather than any contractile myoepithelial cells. Okay, so what does this mean for us? So the luminal cells will generally stain with a low molecular weight keratin. The outer cells may stain with a high molecular weight keratin, and certainly basaloid markers like P63, P40. If they're of the contractile variant, they also contain contractile filaments, right? So myoid markers like SMA, calponin, et cetera. So you can see how between the molecular weight of the keratin and the basal markers, you can sort of differentiate between these essentially 3 cell types, with the myoepithelial and the basal being very similar. SOX10 DOG1, S100 can also be used variably, but aren't quite as discriminatory because they can be variably positive or negative in the various types of cells. Okay, here's another chart for those of you who like this kind of outline, just highlighting what stains are positive in what cells. It can get very complicated, so I try not to hinge on this, this complex pattern, but just know that it's there in case you ever want to highlight something in particular. So looking at it a little bit more simply, we have the acini in the top row, the intercalated duct, then the striated duct, and then the excretory duct. And you can see how the myoepithelial cells are staining with CK56 throughout, are staining with P63 throughout. And then the contractile ones have the SMA in these smaller units. You can see around the intercalated duct, but essentially SMA is absent, right, in the striated duct. So in case you didn't believe my diagrams, it's true, it works in reality. The contractile cells transform to more basal cells as you get to the larger ducts. Okay, so that being said, let's take a little bit of a closer look at the myoepithelial cell phenotype and why this matters. So myoepithelial cells can be of both varying morphologies as well as having various immunoprofiles. So you can start with something that's very chondromyxoid, like we see in a pleomorphic adenoma. These cells are all myoepithelial cells. You can see something very spindled without that myxoid background. You can see these so-called hyaline or plasmacytoid cells, as you can see with glassy cytoplasm and eccentric nuclei. And you can see sometimes clear or epithelioid cells with a pale cytoplasm. What's common amongst all of them, interestingly, is the most strong marker, I think, is in fact calponin. And so when we think about myoepithelial tumors, whether they be in salivary gland or soft tissue, I'll often ask you guys to order a calponin because this is positive regardless of the morphology in most cases. You can see the SMA and the S100 and the high molecular weight and the P63 can be quite variable, but we can use all of these to aid in our diagnosis of a myoepithelial cell. Okay, the hyaline plasmacytoid cells are diffusely and strongly positive for S100, but essentially negative for SMA and P63, just FYI. Okay, so when we put this together into a differential diagnosis of a tumor, I always start by looking at how many cell types are in this tumor. Are there 2 cell types, 3 cell types, or 1 cell type? And can you distinguish those cell types on H&E, or do you need immunohistochemistry to distinguish them? So pleomorphic adenoma, basal cell neoplasms, adenoid cystic, epimyoep, all have 2 cell types that you can highlight with basal or myoepithelial markers. Oncocytoma, oncocytic carcinoma, and Warthin are here because even though you really cannot tell that these are of 2 layers because they all look just like oncocytes, there actually are P63 positive oncocytes at the periphery of some of these nests that we'll see later. But even though it looks like a single cell type, it's actually 2 on IHC. Mucoep is really the only one that has 3 cell types, which we'll talk about later. In the tumors with a single cell type, some of them are either of epithelial phenotype or of myoepithelial/basal phenotype. All of these lists and charts are here for your review, and we'll get into the details about these individual tumors in a bit. And so our differential diagnostic groups include those with basaloid cribiform tubular morphology, those with a microcystic or secretory or mucinous architecture, those that are solid to nested with clear or spindled cells, and lastly, those that are oncocytic or oncocytoid. Questions before I go into these differential diagnostic groups? I think that looking at tumors based on morphology is going to be most helpful because, right, when you're looking at a biopsy or even a resection, you start with what you see, right, rather than what it is. So I think this is the most helpful approach to go over them. All right, so the basaloid neoplasms are neoplasms that appear so-called blue on low power, meaning they have high NC ratios, not necessarily meaning they're malignant, but they're very cellular. Their architecture may be varied, including cribiform, tubular, or solid, and occasionally they may have a myxoid stromal background. So we're going to start with the answers and kind of work our way backwards. So these are 4 different tumors, top left, top right, bottom left, bottom right. Does anybody have any thoughts or know what any of these might be? If so, type it in the chat. Some of these you might be able to get a better idea on just based on the H&E, but you can see how they're all quite similar, right? They're all very cellular. The cells are compacted. They have various architecture, including, ductal, cribiform, tubular. All right, no one has any ideas. So the morphologic clues are, all right, someone is saying adenoid cystic top left. So yeah, so this is cribiform with this very bluish gray myxoid material that in fact is adenoid cystic. Something basaloid on the top right, good thought, because this is basaloid neoplasms, basal cell adenocarcinoma, basal cell adenoma have very kind of jigsaw puzzle-like tubules with eosinophilic basement membrane material. Pink here as opposed to the bluish, right, of adenoid cystic. Bottom ones are a little more challenging. So the bottom left essentially is a tumor of single cell type with nuclear wrinkling. The tumor on the bottom right, you can see maybe actually punctuated by ducts, right? So there's these sheets of cells, but there's punctuation by ducts. And so in fact, yep, top left is adenoid cystic, top right are basal cell neoplasms, bottom left is polymorphous / cribiform adenocarcinoma, and bottom right is actually a very cellular pleomorphic adenoma. Remember that PAs don't have to have chondromyxoid stroma. If they do, you're lucky, but if they don't, it can be a little bit more of a challenge. All right, so the first thing I always want to do when approached with one of these neoplasms is just confirm the number of cell types. Do they have a single cell type or a double cell type, and how do we approach that? So for the myoepithelial / basal cell population, we're going to look at a P40, a P63, and sometimes an S100. For the epithelial cells, as you see, we often perform a C-KIT or a CD117. I'll show you why. So here's an example of P40. P40 is the, I would argue, cleanest nuclear marker of a basal / myoepithelial phenotype. And in fact, is a little more clean than P63. So adenoid cystic, you can appreciate the peripheral and the tubular myoepithelial cells. Same with basal cell neoplasms. You can see there's a basal cell layer at the periphery. Pleomorphic adenoma certainly has an inner epithelial and an outer myoepithelial cell type. But polymorphous and cribiform is completely negative for P40, confirming that this is in fact of single cell type. So this is the only tumor really in this particular differential that contains a single cell type. So if you're convinced that it's one of these and you have a negative P40, you can pretty much make a diagnosis of polymorphous / cribiform adenocarcinoma. Unfortunately, as I said, P63 is not as clean. You can see that polymorphous has some P63 positive nuclei in there, which is why I do not like P63 as much as I like P40, especially for this differential diagnosis. All right. P63 essentially stains the same as P40 in the other 3 neoplasms, but it's different in polymorphous. Okay. The other immunostain that's very helpful is in this differential, polymorphous is the only tumor that is diffusely strongly positive for S100. Okay, so we saw how the immunoprofile of S100 in our chart can be quite variable. This is one of those cases that is diffuse and strongly positive. In adenoid cystic, as well as in PA, it can be somewhat patchy, and it doesn't have quite as clean of a geographic distribution as we might expect. Like, it's not obviously staining the myoepithelial cells or the epithelial cells. It's just kind of a little bit dirty. Interestingly, in the basal cell adenomas, you have S100 diffuse strong positivity in these spindle cells of the background stroma between these nested glands and ducts. So just something to keep in mind that can be helpful with S100 in basal cell adenomas. Okay, one kind of caveat is that S100 can be positive in diffusely strongly, right, in the hyaline plasmacytoid cells of a pleomorphic adenoma. So if on a small biopsy, all you get are these hyaline plasmacytoid myoepithelial cells, I wouldn't necessarily be 100% convinced that these are, that this is a PA versus a polymorphous cribiform. You can see these high power views of both that are quite overlapping. And you might remember that the hyaline myoepithelial cells are also negative for P40, P63. So on a very, very small biopsy, you could just be getting an isolated area of a PA as opposed to a polymorphous cribiform. But if you have a larger biopsy or in fact a resection, then this pattern can be helpful if present diffusely. Okay, so c-KIT or CD117, I already mentioned as a marker of epithelial differentiation. And the two tumors that I think this is helpful in is adenoid cystic and pleomorphic adenoma, top left and bottom right, as you can see, because it quite distinctly stains the epithelial cells here compressed within this sandwich in the adenoid cystic. And it also stains the epithelial tubular or ductal cells of the pleomorphic adenoma, and the background myoepithelial cells are negative. If you notice in the top left adenoid cystic, in the cribiform areas at least, the epithelial cells are essentially sandwiched between the myoepithelial cells, which are negative. The myoepithelial cells are the ones that produce that basement membrane material that either can appear bluish or pinkish. So this specific distribution is very helpful. You can see that in polymorphous cribiform, c-KIT's kind of weak and patchy, and in basal cell neoplasms, it's essentially diffusely positive, maybe with a little bit weaker in the peripheral cells, but essentially kind of positive throughout. So c-KIT highlights those epithelial cells of adenoid cystic and PA, nonspecific and nonspecific. Okay, so once we have this immunoprofile, what else might help in the event that there's still some morphologic or immunophenotypic uncertainty? And that is, of course, going to be genetics. And so some of these genetics have immunohistochemical correlates and some of them don't. And when they do, I will discuss them. So here we have the genetics of all 4 tumors, with adenoid cystic being common to have NFIB rearrangements, either with MIB or MIB-L1. Pleomorphic adenoma having PLAG, right, pleomorphic adenoma gene rearrangements, followed by HMGA2. Polymorphous and cribiform adenocarcinomas have problems with the PRKD gene family, whether that be mutations or rearrangements. And basal cell neoplasms have CYLD or beta-catenin mutations, depending on whether they're an adenoma or a carcinoma. So looking in a little bit at adenoid cystic, you can get MIB protein expression in most cases. Remember that MIB is partnered with NFIB, so it results in MIB overexpression. Usually this is nuclear and in the peripheral myoepithelial cell layer. The caveat is that you can have rare expression of MIB in other basaloid neoplasms in the absence of a gene fusion. So the genetics arguably are a little bit more specific than the immunostain, but if you have MIB in various labs, you can try to use it. I don't use it here. The other thing we can see in adenoid cystic, especially in some aggressive tumors, are Notch1 mutations. There's also a Notch1 immunohistochemistry, which can either be of subset positivity implicating a wild type Notch, or of diffuse positivity, usually indicating a gain of function mutation of Notch. We don't have Notch1 mutation, Notch1 IHC here, but we certainly can look for Notch1 mutation on our OncoPlus panels. Again, the so-called subset positivity can be present in other tumors in the absence of gene mutation. Okay. Polymorphous and cribiform, I tend to put together mostly because they're essentially the same or very, very similar tumor morphologically and immunohistochemically. They tend to be located either in the palate or other minor salivary gland sites, and are basically differentiated not only by location, but also based on the presence of that PRKD1 point mutation versus that PRKD gene rearrangement, which tend to co-localize either respectively to the palate or to the other minor salivary gland sites. It's interesting. The significance yet is unknown, but this does not have any immunohistochemical correlate. Basal cell neoplasms, as I said, can either have mutation of beta-catenin or CYLD. Remember, CYLD is the gene implicated in dermal cylindromas. You might notice a morphologic similarity between a dermal cylindroma and a basal cell neoplasm, the jigsaw puzzle, the hyaline basement membrane material. In adenocarcinomas, you only have CYLD mutations. You don't really have beta-catenin mutations. But in the adenomas, you can have either. CYLD protein can be expressed in both mutant and wild type basal cell neoplasms, as you can see here, but hasn't really been adequately studied in other tumor types, so I'm not really sure the significance. I do sometimes use beta-catenin and basal cell neoplasms as aberrant nuclear beta-catenin expression can be present, especially in the peripheral myoepithelial cell layer of basal cell adenomas. And should be negative in your other tumors in this differential adenoid cystic polymorphous PA. So sometimes we do use beta-catenin. There are occasional epithelial myoepithelial carcinomas that also have beta-catenin. So of course, most of these stains come with an exclamation point, a caveat, but know that we use them in certain circumstances. Beta-catenin mutation per se is not present in necessarily basal cell adenocarcinomas. Remember, only in basal cell adenomas, but you can have beta-catenin both membranous and membranous nuclear expression in the carcinomas in the absence of gene mutation. LEF1 sort of recapitulates what is seen in beta-catenin, where it's positive in the peripheral kind of myoepithelial or basal cell layer. So sometimes we use both beta-catenin and LEF1. We in fact do have LEF1 here. I believe it's used a lot in heme, but we've thrown it on a couple basal cell neoplasms with success. Okay, PLAG. So PLAG and pleomorphic adenoma, there is an immunohistochemical stain for PLAG that is overexpressed in the nucleus, but it can be positive in other tumors in this differential, including polymorphous, basal cell neoplasms. So I do not think that this is a specific enough stain for use in general practice. The rearrangement, however, if found on genetics, is. Similarly with HMGA2, the genetics are much more specific than the immunostain, but it does exist. Okay, so I have a lot of summary charts here, so you can review your morphology and clinical picture and immunoprofile of these salivary gland neoplasms. Remember, polymorphous and cribiform are tumors of a single cell type, but of various histologic patterns, including tubular, cribiform, sometimes whorled or glomeruloid, either on the palate or other minor salivary gland site, both being negative for P40 and diffusely strongly positive for S100, and being differentiated by what type of PRKD gene rearrangement is present. Here's another example of the morphologies of these two tumors. Again, sometimes with a little bit of myxoid stroma, as you can see here, with perineural invasion being present. Okay, basal cell adenoma and adenocarcinoma are essentially distinguished by either being non-invasive versus invasive. They have this jigsaw puzzle-like architecture with peripheral and central eosinophilic, very globular kind of hyaline basement membrane material. They do have those P40 positive, sometimes beta-catenin positive cells at the periphery. The architecture can vary from tubulotrabecular to solid to cribiform to membranous. Membranous is the one that you can see here recapitulates the cylindromas of skin with these, again, jigsaw puzzle basement membrane material, but all of these other patterns are possible in basal cell neoplasms. Here's an example on lower and then higher power of what these might look like, right? Extremely blue, but they're noted by this very prominent peripheral palisading layer at the periphery of the nests and these eosinophilic hyaline basement membrane globules kind of in the center of the nest, very characteristic. This is just a bottom example of here showing an invasive counterpart, a basal cell adenocarcinoma with a little bit of squamous metaplasia. So one thing I'll mention now, since it's here, is that squamous metaplasia is one of those features that can be present in pretty much any salivary gland neoplasm. So you can always think about squamous metaplasia, mucinous metaplasia, sometimes even sebaceous metaplasia that can occur in salivary gland neoplasms. That doesn't mean that that is necessarily a diagnostic feature of that tumor. So you have to sort of take into account how diffuse are those areas? Do they fit in the context of what you're expecting for the remainder of the tumor? But remember that metaplastic changes can happen in many, many neoplasms. Okay, the last couple review on this differential, right, are of course going to be pleomorphic adenoma and adenoid cystic carcinoma. They're put together here because they both have P40 positive myoepithelial cells and c-KIT positive epithelial cells. So they both show that beautiful biphasic distribution, but are generally different in their architecture, with adenoid cystic tending to have more cribiform, but you could certainly see cribiform areas in PA. Chondroid stroma being specific to pleomorphic adenoma, but myxoid stroma not being specific. And sometimes this differential can be very challenging, especially on a small biopsy, because of the morphologic and immunophenotypic overlap. So you can see on the left a pleomorphic adenoma that on a small fragment might have very worrisome cribiform architecture seen on the bottom left, which very much resembles the cribiform architecture of an adenoid cystic. And really only on resection are you able to tell that the tumor on the left is completely circumscribed and would otherwise represent a pleomorphic adenoma. There's maybe a little bit of chondroid stroma right here, and the tumor on the right being definitively infiltrative and definitely being an invasive carcinoma. So sometimes it's not until resection that you're able to definitively differentiate between these types of neoplasms. Again, here's showing, just to hit home, that squamous metaplasia and a little bit of squamoid metaplasia in these tumors as well. All right, so this is our summary of our important immunostains as well as our genetics. Does anybody have any comments or questions? You know, I'm happy to send this around. Obviously, the recording will be here for you guys to look at these in more detail. But before we move on to the next differential diagnosis, does anybody have anything? Okay, I know it's a little bit of a whirlwind, but we always have to take into account all of these neoplasms when looking at a salivary gland tumor. The other tumor that I haven't mentioned yet that may come up in the biphasic neoplasm differential is epithelial myoepithelial carcinoma. We will discuss this subsequently. What I will point out right now is that immunohistochemistry may not help in discriminating this from other biphasic tumors with epithelial and myoepithelial cells, like even a pleomorphic adenoma. The morphology that we see that's slightly different is this very prominent, clear myoepithelial cell population that kind of has expanded around the luminal epithelial cells of the ducts, right? So I'm highlighting here the luminal epithelial cells, but the background is just full of these very clear myoeps. This is very characteristic of epithelial myoepithelial carcinoma. And we'll talk more about this later, but just always keep this one in mind as another biphasic type of tumor. Okay, so here are the biphasic tumors in which myoepithelial cells or basal cells are a component, right? Adenoid cystic, pleomorphic adenoma, any of your basal cell neoplasms, adenoma or carcinoma, and epimyoep. Things that might differentiate them morphologically include the angulated dark nuclei of adenoid cystic with very frequent perineural invasion. Pleomorphic adenoma certainly should be circumscribed. The chondroid stroma will be diagnostic if you can see it. Basal cell neoplasms have that peripheral palisading with very pink basement membrane material, and epithelial and myoepithelial tend to have lobulated growth with those very, very clear cytoplasm of the myoepithelial cells. So I've tried to put many, many charts because there are many, many ways in which one can frame any of these neoplasms. All right, so moving on to the microcystic, secretory, and mucinous. These tend to be tumors with uniform cytomorphology, having cystic to solid architecture, sometimes having intraluminal or intracytoplasmic vacuoles or secretions. So again, 4 different tumors, but very similar. Does anybody see any clues in any of these that might help them in their differential diagnosis? This is a tough one. So the morphologic clues here are, in the top left, we have cells that maybe show a hair of intracytoplasmic mucin. On the bottom left, we show cells that maybe have more purple zymogen-like granules. I know the mucin and the zymogen granules can sometimes look similar, but I'm telling you, these are more granular. The one on the top right is a little bit of a too high power view, because more often the tumors on the top right tend to be macrocystic as opposed to microcystic. And then on the bottom right, we have these secretions that range from being kind of milky or watery to being very dense and eosinophilic. So yeah, so some of you are saying mucoep, top left, because it's cystic with a mucinous vacuole, acinic cell granules on the bottom left, exactly, and possibly secretory carcinoma on the bottom right. Well done. The thing we're missing is on the top right. So the top right is actually an intraductal carcinoma, which I will get to more definitively in the next slides. But exactly, those are the very, very, very subtle morphologic clues that are going to help you distinguish these. But oftentimes we do have to use stains or in fact genetics. So should we take the same approach before and confirm the number of cell types with myoepithelial markers? Sure. So in using our P63 and P40, we are able to determine that mucoep is usually positive in the vast majority of the cells. Both the intermediate as well as the squamoid cells are positive for P63, P40. So that's the majority of cell types in mucoep. Mucinous cells are usually scattered in between. You can see them here with the pale cytoplasm, but every single other cell is positive. In the intraductal carcinoma, it is what it says it is. It is essentially a carcinoma in situ that is proliferating within a duct. So your myoepithelial or basal cells are only going to be present at the periphery, just like in a DCIS of breast or something, okay? However, acinic cell and secretory are both completely negative for P63, P40, so that's going to be helpful. S100 as well can be discriminatory in the fact of it's diffusely strongly positive in both intraductal carcinoma as well as secretory carcinoma. So S100 is kind of patchy or negative in mucoep and certainly negative in acinic cell. So now we're starting to have a differential breakdown between your myoepithelial markers as well as your S100. All right, so that's going to be very helpful. And lastly, mammoglobin. Mammoglobin tends to behave very similar to S100, being diffusely strongly positive in both intraductal and secretory, and being patchy or negative in mucoep and acinic. So these are all very helpful. The next one is going to be DOG1. So DOG1 was recently noted to be present in acinic cell, either in apical or membranous fashion, or just diffuse strong membranous and cytoplasmic. It's essentially negative in secretory, negative in intraductal, and relatively negative in mucoep, minus perhaps a little bit of apical or luminal staining of the mucinous cells. So DOG1 can be useful if those other stains are not. The non-immunostain, right, just the regular special stain that I love to use in salivary neoplasms is PAS diastase. So as you guys hopefully remember from our Jeopardy, right, PAS diastase, the glycogen is digested out with diastase, but mucin and zymogen granules are not digested out, so they retain. The difference in the characteristic of the PAS staining can help you determine whether what you're seeing is mucin or zymogen, right? So on the top left, the mucin is very homogeneously staining, as you might expect from mucin. Whereas in the acinic cell on the bottom left, you're picking up the granules, right? The pre-digestive enzyme granules in their little like vacuoles or their lysozymes or whatever they're in. And they are more punctate, more spotty, rather than this homogeneous mucin. So yes, the PASD is going to be positive in both, but you really have to take into account the quality of the stain. It should be totally negative in intraductal, and it should be essentially negative within the cytoplasmic compartment of secretory. Sometimes your secretory material will retain the PAS, but the actual cells themselves should be negative. And always remember that PAS, we are really only evaluating in the intracytoplasmic compartment. We don't really care in this case, in these cases, about what it stains of the luminal contents. We only care about the contents of the cytoplasm. Okay. Warning that pseudozymogen granules, which are actually hemosiderin, sometimes happen and have been reported in secretory carcinomas. And so iron stain, if you're ever like, this doesn't make sense, why is this staining? I think this is a secretory carcinoma, maybe throw an iron stain on there. And if those areas are staining with iron, you know they're hemosiderin and not actual zymogen granules. So I thought that was an interesting, I've never seen it, but it has been reported. Okay, so in addition to those immunostains, I think in this differential diagnosis, immunohistochemistry is quite helpful. However, we often also refer to genetics in some of these cases. So as a reminder, right, the genetics of mammal 2 rearrangement are highly specific for mucoep. Intraductal carcinomas have RET rearrangements. Secretory carcinomas have ETV6 rearrangements. And now we're starting to learn that acidic cell carcinomas also have abnormalities in the NR4A3 and MSANT-D3 genes. So, you know, salivary, I think, used to be more of a black box, and it was monomorphic adenoma versus pleomorphic adenoma, and everything else is malignant. But I think it's very interesting now that we know quite a lot more about genetics than we used to, and in fact is extremely helpful in diagnosis if the morphology or the immunoprofile is not helping you. Mucoep is, as I said before, mammal 2 gene rearrangement is highly specific, with the partner being either CTRC1 or 3. Just, you know, to toot a little bit of our own horn, we reviewed over 50 mucoeps and realized that the morphology highly correlated with the presence of mammal 2 rearrangement regardless of grade. So there were these papers out there that used to say, oh, high-grade mucoep just doesn't have mammal 2 gene rearrangement. Isn't that interesting? Well, if it doesn't have mammal 2 gene rearrangement, it's probably not a mucoep. And if it does have mammal 2 gene rearrangement, it probably is a mucoep. And the subtle morphologic features and mucinous cells can guide you in the right direction. The other thing that we looked at were grading systems. So I do think the grading of mucoep deserves a comment here, even though this isn't, you know, grading isn't the gist of this talk. I will mention it here. So there are 4 different grading schemes that have been proposed for mucoep, ranging from two quantitative and 2 qualitative. You'll note that in the Brandwein system, the presence of any 2 of these features, intracystic component being low, perineural invasion being present, necrosis, high mitoses, nuclear pleomorphism, invasive border, LVI, bony invasion, any 2 of those features render this patient a high-grade cancer. 0 or 1 feature make it either low or intermediate grade. The features that I would argue are more important, that are really present only in high grade, never in low intermediate grade, are PNI and necrosis, very many increased mitoses, nuclear pleomorphism, and lymphovascular invasion. When we graded these tumors in all of the 4 different systems, the Brandwein intermediate and low grade tumors actually behaved quite similarly with very low to no recurrence as compared to the high. You can see how the other 3 systems performed somewhat differently, with the one on the bottom left here, the AFIP system, actually being kind of the worst. So what we've done is we've taken Brandwein as our kind of gold standard and saying anything brandewine low grade or intermediate is essentially biologically low grade, and anything brandewine high grade should potentially be treated as if it's biologically high grade. So this helps for treatment purposes because sometimes clinicians don't know what to do with these middle intermediate grade lines. But because these systems all score them differently, we're going to stick with one system, and we're going to stick with the system in which intermediate basically behaves like low. So I think for clinical purposes, that's a helpful dichotomy to use, even though it hasn't really been accepted diffusely by the population. This is what we tend to use. Okay, questions? All right, so moving on to the additional differentials of secretory carcinoma. As you know, having ETV6 gene rearrangement, which is histologically and genetically identical to those same tumors found in the breast, the skin, the thyroid, even the lung. The importance here is that these, the tumors that are NTRK rearranged, which is the vast majority of them, are treated with NTRK or can be treated with TRK inhibitors. And so there is a TRK immunostain, which we don't have here, but apparently is thought to have nuclear expression, but can have cytoplasmic expression in various other tumors. So in this case, TRK expression is going to be specifically nuclear, but arguably genetics are still more specific than immunohistochemistry, but there is a TRK immunostain out there. A cynic cell has been shown in a small percentage of cases to have M-Sant D3 rearrangement or gain. This encodes a gene called HTN3 gene encodes HTN3, so that's the partner of M-Sant, that is secreted exclusively in saliva. So interesting, a gene that's very specific to a salivary type of lesion. It's thought that the M-Sant gene is overexpressed under the control of the HTN3 promoter. This is so new, there's really no immunohistochemical correlate yet, but this is out there. Interestingly, even more recently, what was discovered is that more percentage of cynics have the NR4A3 gene rearrangement, usually with the SCPP partner. And so NR4A3, again, is upregulated against the SCPP gene. And there is now an immunohistochemical correlate of NR4A3, where there is aberrant overexpression of NR4A3 in the nucleus of a cynic, which has been negative in other tested tumors. So we do not have this here, but again, this is new. This is out there in the literature. So NR4A3 for a cynic. Okay. Moving into our intraductal. So remember I said this was the one that kind of was like almost a breast, like a intraductal carcinoma or an atypical ductal hyperplasia type of thing, where these are always within a duct bounded by the confines of a myoepithelial cell layer. A lot of these have Brett gene rearrangements. There, as far as we know, is no immunohistochemical correlate to this gene rearrangement. Sometimes these tumors show intercalated duct-like phenotypes. Sometimes they show apocrine or even salivary duct-like phenotypes. I'll mention salivary duct in a bit. Don't worry too much about this, but realize that anything that is confined within a myoepithelial cell layer is generally considered intraductal. But be careful, because occasionally these can actually invade and have stromal invasion outside the confines of those ducts. Okay. Here's salivary duct. And so the reason I put these together is that intraductal carcinoma used to be considered a low-grade variant of salivary duct, but this is, I don't know, no longer really appreciated. So salivary duct carcinoma, when seen, is essentially always a high-grade invasive carcinoma. It resembles DCIS of the breast. It is invasive, but you can have an adjacent intraductal or in situ component. The morphology tends to be of apocrine type, with these so-called kind of Roman bridging or cribiform structures bounding a central core of necrosis. Genetically, they are positive for androgen receptor in the nucleus, HER2 on the membrane, and those that are HER2 3+ tend to actually have HER2 amplification by genetics. Now, just remember that some other high-grade salivary gland carcinomas, in this case, D-diff adenoid cystic, can have either androgen or HER2 expression. It doesn't necessarily make them a salivary duct, right? So you have to take into account the morphology and the co-expression of both AR and HER2. Okay, as I said, only on occasion, other non-salivary duct carcinomas can also have co-expression of androgen and HER2. Okay, we're going to skip that for now. So in summary, we've talked about acidic and secretory, which tend to be most similar on the differential diagnosis, but essentially have a opposite immunoprofile, being S100 mammoglobin negative, DOG1, NR4A3 positive and acidic, and the converse in secretory. Remember, secretory carcinoma used to be considered a microcystic variant of a cynic cell. We now know it is a completely different carcinoma, but we do know that a cynic cell can still have a microcystic variant, that it truly remains a cynic. And again, it'll be the presence of the granules and the and the genetics that will differentiate them. Both can have high-grade transformation. Here you can see to a kind of more, I guess, ugly carcinoma with these large kind of potatoey nuclei, prominent nucleoli, here with central necrosis. So just remember that any of these low-grade carcinomas can have high-grade correlates. Mucoep and intraductal, we also talked about as both having either P63, P40 positivity in the vast majority of cells, or P63, P40 positivity only at the periphery of those ducts. So here's showing a more characteristic mucoep with a number of mucinous cells lining those cystic spaces with the intermediate and squamoid cells, and then the intraductal carcinoma with these basal or myoepithelial cells at the periphery and these kind of papilliform structures projecting into the lumen. Okay, so here's our table summary of those four, including our immunostains, our genetics, and on occasion, the associated IHC. I want to spend 2 seconds talking about tumors that are diffusely S100 and mammoglobin positive. So other tumors that are diffusely and strongly S100 positive, you may remember from before, is our polymorphic cribiform. So because there are so few tumors of salivary gland that are diffusely strongly S100 positive, I just wanted to highlight them in this chart so that if you ever do get a case, go back and refer to this, because there are other stains that may help you distinguish between these three, which I think are actually quite helpful. All right, just a brief word on GATA3. So you may ask why haven't you spoken about GATA3 yet, especially with all these tumors that resemble breast, right? Like mammary analog, salivary duct, intraductal, whatever. Well, GATA3 has actually been shown to be at least weakly positive in many to most salivary gland tumors. However, it is always diffusely strongly positive in both salivary duct and secretory. They both resemble breast carcinomas, okay. But variable staining has been seen in most salivary tumors. So I don't use it because I don't think it discriminates very well. It's a little out of order, I apologize, but the other tumor that enters into the S100 positive differential diagnosis is actually canalicular adenoma. And, for boards takers, this is one of these characteristic, clinical pathologic correlates of like an older woman upper lip. And so if you have an older woman upper lip tumor that kind of looks like it has these cuboidal to columnar cells with 1 to 2 cell thick cords, sometimes with these little papillary or squamoid like morules in the center, sometimes with myxoid stroma. Think about a canalicular adenoma. These are also, as you can see, S100 diffusely strongly positive, and sometimes have been shown to have a weird GFAP like luminal staining pattern. So just mentioning that so you know that this is out there. It's very rare, but really think of it in this clinical context. Okay. So just to recap, this is a summary of the monomorphic tumors in which myoepithelial cells are not a component of the tumor, right? So that's our S100 strongly positive tumors like intraductal, like secretory, like polymorphous cribriform, like canalicular adenoma. I'm throwing in there acinic cell as well because that is a monomorphic carcinoma. It just doesn't have S100. So, right, based on the presence of a peripheral myoepithelial cell layer or not, the presence of S100 and or mammoglobin, occasionally DOG1, and certainly genetics, you should, in most instances, be able to sort through these. If you use your immunostains cautiously and sparingly, and don't just throw things on there that you don't know how to interpret. But these are the ones that I like to use. Okay, so you can see already how a lot of the markers we use for these differential diagnoses are overlapping, like P40, P63, and S100. Sometimes, if your differential varies, you may use mammoglobin, you may use c-KIT, right? But you're not necessarily going to use them all for every differential diagnosis. You're going to pick and choose wisely depending on what your suspected diagnoses are. Okay. In the last few minutes, we'll talk about the tumors that are more solid and nested morphology. So here are our four. I'll let you think about for about 2 seconds about what they are, but I won't belabor the point. So you can write it down for yourself and tell me later if you think you're right, or type it in the chat if you want. I don't care. I think the one on the top right is probably the most diagnostic. That being, yeah, clear cell carcinoma. So these are cells that have diffuse cytoplasmic clearing, wrinkled nuclei, eosinophilic hyalinized stroma. The one on the top left is kind of sheets of cells, very nondescript, but with a hair of myxoid stroma. On the bottom left, you have, again, sheets of cells, but maybe you can see that they're punctuated every here and there by a little duct, all right? So that should make you think about something. And then on the bottom right, you have more of a densely eosinophilic cytoplasm, maybe with like even diskeratotic cells, and maybe very well-defined cell borders. So we have clear cell carcinoma on the top right, myoepithelial carcinoma on the top left, epimyoep on the bottom left, and squamous on the bottom right. And so these are all here together because they essentially all stain like they could be squamous cell. So they all have P63 and P40 positivity. Of course, if you're an epithelial myoepithelial carcinoma, you're not going to have P63, P40 positivity in the ducts. But remember, in epimyoep, the vast majority of the cell population is actually the myoepithelial cells. The epithelial cells are sparse or scarce, okay? So P63 and P40 are going to be highlighting essentially the majority of all of these tumors. Same with high molecular weight keratin, CK5-6. They're going to be highlighting the epithelial, squamoid, basal cells in all of these, except of course the epithelial cells in epimyoep. Okay, oops. So, but those are just the P63s, the P40s, and the high molecular weight keratins. What about the contractile specific markers? So like SMA or calponin, or something like S100 or SOX10. So those are thought to be positive in the myoepithelial carcinomas and of course the myoepithelial cells of the epimyoep. The squamous cell carcinoma, as well as the hyalinizing clear cell, should not show the contractile markers, right? So because they are not myoepithelial cells, they're other, right? They're other. So you should only see the myoepithelial specific markers in the tumors on the left, if that makes sense, okay? So now I'm going to interject here a word on SOX10. So why am I highlighting SOX10? It has been shown to be positive in most salivary gland tumors to varying degrees, and I think is not really helpful in a number of differential diagnoses, with the exception of the one we're talking about here. So it is negative in clear cell and squamous cell carcinoma, which we've seen. It's negative in salivary duct. It's negative in oncocytic tumors and most mucoeps. So if you have an occasion to use SOX10 in a particular differential diagnosis of which any of these tumors fall, use it, but I only use it cautiously and with this kind of very specific differential diagnosis in mind. Okay, so as you can see, the immunoprofile of these tumors is quite overlapping, especially in these 2 rows here. So what else is potentially going to help us? So let's talk about the genetics. So myoepithelial carcinoma tends to have EWSR rearrangement, especially in those with clear cell morphology. That looks kind of like the clear cell carcinoma, which has EWSR ATF1 gene rearrangement very specifically. Epimyoeps have recently been shown to have HRAS mutations, so kind of interesting. And squamous cell carcinomas of salivary gland generally are not primary. They are most often considered metastases, especially from places like skin, in which they may have UV signature mutations, or places like the nasopharynx, or even the oropharynx, in which they may have EBER, or for oropharynx, HPV virus. So hyalinizing clear cell carcinoma is probably the most recurring to have the EWSR ATF1 gene rearrangement in the vast majority of cases. Just remember that if you see a tumor that stains like a squamous cell carcinoma, right, P63, P40, high molecular weight keratin, but does not stain like a myoepithelial carcinoma, right, no SMA, no calponin, think of this tumor, right? So think of this tumor in the salivary glands. Sometimes it has a prominent hyalinized stroma. Sometimes it doesn't, which is why the hyalinizing is now gone from the name. Sometimes it has very prominent clear cells. Sometimes the clearing is less prominent, but just consider this in your differential if nothing else fits. If you think it could potentially be squamous based on the immunoprofile, just take a look at the grade. Usually these aren't quite as high grade as squamous. You shouldn't see as many dyskeratotic cells. You shouldn't see as many mitoses. So just keep that in mind. It's sort of like squamous, but like squamous immunohistochemically, but not like it morphologically, and certainly not like it genetically. Okay, myoepithelial carcinoma tends to have this kind of very broad-based lobulated morphology with this central kind of necrotic area as seen here. If they have clear cell predominant morphology, they tend to have EWSR rearrangements, but not the EWSR ATF seen in clear cell carcinoma. So it's EWSR, other. The morphology of myoepithelial carcinoma is very similar to that of epimyoep, again, with this lobulated border with central necrosis. But again, what you'll see is this punctuation by these duct-like structures, which you can certainly highlight by a low molecular weight keratin, maybe by a c-kit, and certainly by absence or by negativity for your myoepithelial markers. Just as a reminder, HRAS mutation in a number of these tumors. Okay. The last word on squamous cell carcinoma. Generally, you're going to find these in the parotid. Generally, they're going to be metastases from the skin, and you can prove it by having a UV signature with a C to T or a CC to TT base pair change. If you have a tumor that kind of looks like almost a quote unquote lymphoepithelial carcinoma with very non-keratinizing morphology, with lymphoid stroma, think about it being coming from the nasopharynx or oropharynx. So think about doing your EBV. Think about even doing your HPV, although these are going to be less frequent than just the classic keratinizing skin cancers. All right, but anything is possible. So here's your chart of these types of tumors and your summary tables. Since it's getting to be 9 o'clock, I won't belabor these, but I will leave the PowerPoint and the recording for you to review. The last tumor type that I didn't go over in detail, but let's just for 2 seconds talk about the oncocytic and oncocytoid tumors, of which your diagnoses are essentially oncocytoma, oncocytic carcinoma, a very oncocytic or apocrine-like salivary duct carcinoma, and an oncocytic mucoep. It's, to me, interesting that there have been now shown these oncocytic mucoeps that essentially are mucin poor or mucin negative, but are diffusely positive for P63 and have MAML2 gene rearrangements, right? So this is in contrast to oncocytomas, which actually do have a peripheral P63 positive layer, which you really can't see on H&E, right? Which is why you're like, no, oncocytoma is one cell type. Well, actually, it's kind of two based on immunostains, where you do have a P63 positive peripheral layer, but you do not have mucin and you do not have mammal-2 rearrangement. So this has been an interesting development recently. Similarly, with your oncocytic carcinoma and your oncocytic salivary duct, generally your P63 negativity and your positivity for androgen HER2 should differentiate. But really, once you're at a high-grade carcinoma, probably splitting hairs between an oncocytic and a salivary duct is not important. What is important is just doing the AR and the HER2, because if it's AR positive and or HER2 positive, the patient can be treated. Like, I don't care if you call it oncocytic or salivary duct. What's more important is that there is now a treatment pathway for these patients, right? So sometimes we like to name things, but let's just remember that sometimes it's actually how these patients are going to be treated that's more important. I didn't mention Warthin here because I think even though Warthin tumor is oncocytic, generally it's not a challenge. Generally it has that prominent lymphoid stroma. And if you see a tumor that is oncocytic but does not have lymphoid stroma, it's probably Warthin isn't going to come up in your differential. So that's just my 2 cents on why Warthin isn't here. And Warthin doesn't have any genetics, and it's actually probably not even a clonal neoplasm. It's probably just a hyperplasm or a reactive change. So my last word is going to be distinguishing benign and low-grade carcinoma from high-grade carcinoma is the most important thing you can do. I know today we talked a lot about the subtleties of immunostains and the subtleties of genetics, but these things can certainly help you when trying to diagnose between benign and malignant in a biopsy or in a resection. Okay, so those are our morphologic patterns. Remember always the number of cell types, but let H&E always be your guide to determine what immunostains you're going to order and what genetics you might want to probe for. So here's a table of how these things overlap. The cystic secretory mucinous types, the basaloid types, the solid nested types. So hopefully these charts and tables will help you. Hopefully we can put some of these things into practice next week when we do our biopsy session. So thanks for putting up with me. I hope that was helpful. I know it was a little bit of a fast lecture.